segmentation? What are the advantages, disadvantages compared to using CT?
Hello, everyone. Thank you for these questions. Well, actually, in this model, we do not use MR segmentation to acquire the acoustic properties. It's a rather simple model, and we use MRI to obtain geometric properties of each medium for skin, skull, and brain, and we get acoustic properties from the literature. So each medium is homogeneous. And of course, CT is more detailed, but it requires ionizing radiation. And in practice, we use MRI to conduct the operation. So it will be very nice to have a possibility to obtain acoustic properties from MRI.
Okay.
Okay, Rosita, you had a very interesting talk just with your experience doing these remote treatments. So I guess just maybe you could tell us generally, what was the hardest part that you found with having that remote interaction for your first patient treatment?
Hello, everyone. Thank you for the invitation. And telling the truth, we are the first in Russia medical center presenting our experience in using MRG-FAST for neurosurgery. Actually, it was our idea with Insightec to start remotely due to the COVID infection. And the most difficult part was to select properly patients and then to do everything step by step. First operation was very long. It was 24 minutes, but now we have around 110 minutes. And I think the most interesting thing is that I have, as a neurosurgeon, realized that even very, very difficult neurosurgical procedures can be done remotely with the support, proper support, preparation, and great teamwork. Because we are very thankful for Insightec company and our applicators as Paul Rack from London and Tessa Case from Malaga and Daniel Molchanov from St. Petersburg. They're very helpful. It's something like when we work together, it's something like we're in one room, collaborating, finding the new ways and going 1 millimeter higher, 1 millimeter middle. So it's something like working together without kilometers dividing us. So my talk was about telling people, inspiring them that even difficult things can be done now with using digital approach and proper teamwork. Thank you.
And one just quick follow-up, how many cases have you now done remotely?
Yeah, we have already done 23 cases with them, and we have been certified as an independent center on 29th of October. So now we can do it by ourselves. But due to the COVID, we had so long period of working together with great people. And from my point of view, I'm a little bit happy because it helps us to increase our experience and feel our team more confident.
Well, congratulations on getting certified and reaching that milestone under pretty difficult conditions.
Thank you. Thank you very much.
We have a question for Song Tao. Did you attempt to this method in the context of continuous waves on occasions? Do you think it will hold up moving from a 5-cycle pulse to continuous wave?
And the way to experiment up to 10 cycles is work well. But if we up to such as 5 cycles or 1,000 cycles, it's not working well. And based on the simulation, it can up to 200 cycles, but we will explore it.
And I guess a little bit more on that topic. So it seems like detecting a single cavitation source is much more easily done. So when you have multiple sources and the closed form solution is maybe not as readily available, do you have more challenges, and do you think you can overcome those?
Yeah. For the algorithm, we use the time difference arrival. This algorithm just for each sequence of the signals, we just produce one time delay. So for now, we just for one source, but if we want to expand it into multiple sources, it's also workable. We have to separate the signal for each the cavitation. We have to define it at once and do that. But now it's for just one source. Yeah.
Okay, and one last question. Someone's asked how the setup might handle a cavitation event that occurs outside the skull, so that where some of the receivers are obstructed and are not receiving signal.
Yeah, in this case, I thought it shouldn't working because we just have 4 sensors. If one is blocked, it's couldn't to give a position in 3D. Yeah.
Thank you.
Thank you.
There's a question for Ning. It looks like your acoustic window limits the number of transducer elements you can use. What fraction of the array was active for the histotripsy?
Thank you. And hello, everyone. My talk is on transcranial MR-guided histotripsy in vivo PIC treatment. So to answer the first question, the array was originally designed based on the actual design of MR-guided focus ultrasound system, which is a full hemisphere, and if it's fully populated, it will have 360 elements. But since for PIC treatment, we need to do a craniotomy to remove part of the PIC skull to have an acoustic opening before the treatment, only the bottom portion could actually have space to pass the acoustic window. So therefore, we only populated 128 elements at the bottom portion. And all those 128 elements were actively used for the treatment.
And then there was a question at how long did the sonications take? And also, so how was your MRI guidance done? Because you don't do a thermal rise, you have this histotripsy bubble. Just kind of if you can briefly touch on that. Yeah.
So for sonication time, since histotripsy is different from thermal, it's really not a continuous sonication mode. It's more about one cycle process applied to generate cavitation, and then the overall treatment time will just depend on the pulse repetition frequency you use for the treatment. For this feasibility study, we didn't really try to optimize the treatment time. So we were just using pulse repetition frequency of 10 Hertz, which means we apply one cycle pulse every 0.1 second. And this frequency was used just based on our previous studies, because if you have too high PRF, more than 200 Hertz or even more than that, the residual bubble may hinder the generation of new cavitation events. So we were just kind of use this kind of slow PRF, but if you want to accelerate the treatment time, you could definitely use higher PRF. And the treatment time also depends on the volume you want to treat. We deliver 50 pulses per location. So if you have larger target to treat, the treatment time will be longer. And regarding the MR guidance, we are not currently trying to monitor the thermal effects. So the MRI guidance is more about, firstly, to evaluate the pre-treatment and post-treatment images, just to compare how histotripsy treatment changed the ablate the tissue, and observe if there is any excessive hemorrhage or edema happen due to the treatment. And the second one is we have a specialized MRI sequence developed by Dr. Stephen Allen. So that sequence would allow us to monitor the cavitation events instead of thermal effects during the treatment, which means we can actually see where the cavitation bubble is and just it's kind of similar to the passive cavitation detection, but just using MRI to see if you already have your cavitation generated inside the target volume, and to make sure the treatment is going as we want.
Okay, just a very quick follow-up. So in the pig treatments that you showed for kind of the lesion size, what was the treatment to get this amount, I mean, the multiple locations for this size? Just a rough idea.
So that volume was, I think it was 4 by 4 by 6 millimeter, and the spacing between each of the treatment location was 1 millimeter.
Okay, and then the treatment time, just how long? If you set
So,
that up, just to get an idea.
That's about 10-minute treatment.
Okay. Thank you.
So Jonathan, very nice work. I've seen some of the work that you've published on previous versions of this, and it just seems like you've made huge leaps forward with it. So congratulations on that.
Thanks.
Very nice results. So one of the questions in the chat, and something that I was wondering about as well, it looked like you performed aberration correction on the focusing for the transmit, but not on the received signals. So can you comment on whether or not you can do phase and amplitude correction, and if that's something you are planning on implementing?
Thanks for the question. Yeah, so we can do phase and amplitude correction based on those ACE signals right now, but it's kind of with the caveat that if we don't know the acoustic properties of the skull, which maybe we could get, but if we don't have them, when you correct the aberrations based on the ACE signals, you're correcting them to the location of the bubble, not necessarily to the intended target position. So it increases your pressure headroom by aligning the phases at the location of the coherent source, but it doesn't realign the position of the focus to where it should be if it's not where you intended, if you know what I mean.
Right. So in your case, but you were doing aberration correction on transmit?
Yeah, so on transmit, we did the aberration correction just to ensure that we'd be able to get a bubble to generate the ACE signals that we needed to, demonstrate the receive capabilities and localization aspect of it.
And could you use those same correction values on the receive side without considering using the ACE signals as the to calculate the corrections, but simply using the same as you use for transmit?
Yes, you definitely can. And when you do, you end up getting a fairly decent increase in accuracy on the localization results. So somewhere between 15 and 30% from what I've seen when you do correct the phase aberrations on the image reconstruction.
And have you implemented this? So I see that the system that Ning was presenting being used in vivo. So are you planning on, or have you already moved into some in vivo studies to look at these signals?
So not yet. We have received capabilities on some of our other transducers that we are currently using in rodent studies, but it's not through the skull or anything yet. We do plan on implementing the receive stuff in like Ning's transducer. And for the transducer that was in the presentation, we'll be doing some cadaveric work soon where we're going to try and do the whole thing in a human model.
Well, fantastic. I look forward to seeing that. That sounds very interesting.
Thanks.
So we have about 1 minute to close. So I think for Ning, I had one more question about your pig results, and knowing that we only have about 30 seconds, can you just comment on whether or not you've looked at how well your tissue in your treated volume matched with what your treatment planning or expectations were?
Yes, so just based on the MRI images and histology slides, I think it aligns pretty well. We applied aberration correction for some of the pigs, and I think even with aberration correction, there would be slightly prefocal shift, but the prefocal shift was like 1 to 2 millimeters, so it's really not too much shift.
Great, thank you.
Yeah, thank you very much. And this ends the session now. Thank you.